Good afternoon, and my topic is buckle in unusual situation. So let's see what is unusual. So what the English literature is tell, this is uncommon, abnormal, atypical, unexpected, surprising, unfamiliar, or something different. Okay, so let's see what is something different in buckle. So I'll just have some clinical case, which is like little unusual than the recommendation adult attachment, which is the clear-cut indication of buckle. So my first case is, say this is a 3-month-old baby who was diagnosed and treated for ROP, and after 3 months, there was a segmental almost at 3 clock per hour. There is a retinal detachment, which is in the peripheral part, not involving the macula. So let's see what the literature is telling. So this is a nice article from current opinion in ophthalmology, published in 2008, where they found out that in peripheral retinal detachment not involving macula, when you put a encircles band, 240 band only, the chances of settling the retina is almost around 67%. So it's quite high for a ROP case. And what they have concluded that the most common complication is induced myopia, and for which they this has to we have to remove the buckle usually after 3 months, and in this situation they have recommended that you should put a buckle with a moderate to high buckle effect to get maximum benefit. The most problem during the procedure is raised intraocular pressure, for which repeated paracentesis is indicated. So the take-home message is, in case of stage 4 ROP, scleral buckle is a good procedure. The next question is, this is a 36-year-old male who was injury with a stick, and ultrasound shows there is a induced PVD and vitreous hemorrhage. So, and it is very thick, vision is very poor, need a vitrectomy. So let's see what the literature is, what the medical evidence is telling. Yes, what they have concluded that prophylactic scleral buckle reduces the incidence of retinal detachment after surgery. So the recommendation is encircles solid silicone band 240, 360 degree. The third scenario is this is a 56-year-old male who has undergone a vitrectomy for a trauma, but we have not put a 360 band. At the final checkup, there is a small pocket of SRF inferiorly. There is no clear-cut break. There is a suspected break, which may be pre-existing or may be laser-induced, okay, with a small pocket of fluid. So what are the options? So yes, we can do the laser barrage, but this is not a permanent solution. Yes, we can do a silicone oil removal with endolaser with re-silicone injection, but probably this is a bigger procedure. And the third option is that we can put a segmental buckle, or there is a segmental buckle with a 360 degree belt buckle, with or without randoms. I just find out the literature. This is a nice article in Retina, published in 2014, but they have concluded that the putting a scleral buckle is as effective as the vitreoretinal surgery, and it is less invasive. And the most important thing is that economically it is much better. So in case of silicon oil filled eye, if there is a small pocket of SRF, buckle is one of the option where there is not much PVR changes is there. The third situation is that this is a 36-year-old male who has undergone a pneumoretinopexy, but unfortunately there is a failure. So there is a small amount of fluid is there, small amount of gas bubble is there, and how to manage? So what the option are? We can do a laser barrage, yes, superior nasal, but superior and quite significant amount of SRF is there. So laser barrage, though it is can possible, but probably I think I will not advise. So we can do a vitreous surgery. What about the scleral buckle? So the literature shows that yes, it is an option, but the chances of combination of scleral buckle with a vitrectomy is much better. So in this situation, yes, it can be used. It can be used, but always explain to the patient that the chances chances of vitrectomy is always there. So in case of failed pneumatic retinopexy, we can try. The next scenario is this is a patient who has undergone a successful buckle, but unfortunately after five months, around 6 months after surgery, there is a small atrophic break which is away from the buckle, posterior to the belt buckle, and with a small pocket of fluid, and the fluid is almost touching the arcade. So though it is laser we can do, but it is not advisable, and we can do a vitreous surgery. But what about the revision buckle? Revision buckle, probably I think it is a history now. Though in our early part of our career, we have seen few revision buckle. So I'll just highlight about something about the revision buckle. This is a procedure which is indicated where there is the brake is not in the position, the buckle is not in the position to support the brake, or if the height is not adequate, or the brake is somewhere like some other area, or there is a new brake, or sometimes if there is the CRA patches, the cryo the effect is not adequate, we can do that thing. Okay, and how to do? So suppose the brake is some other place, we can put an additional buckle. Suppose the height is not adequate, we can do little bit drainage to put the things. Suppose there is a new brake, we can additional brake, and suppose there is no CRA, this we can do some more cryo, and or we can put additional buckle over the buckle. Okay, so though this is a very invasive procedure, but this is an option. The next this is a baby who has undergone retinoblastoma treatment, and unfortunately he has a HST in the posterior pole, which is the most common site of break after treatment. So what are the option? Yes, this is our own publications where you have shown that like the scleral buckle is the ideal surgery after a treatment, after the cryo treatment of who patients undergo retinal detachment. This is one more study whose clearly shows that the good anatomical success and with scleral buckle without extraocular tumor extension, which is very important. The next is that this is a 23-year-old boy who having multiple angioma, and patient has undergone like anti-VEGF therapy. And let's see what the literature is telling. Yes, retinal angioma, multiple in the periphery with severe tractional component, even if there is no recommended retinal detachment, scleral buckle, either 360 encircle is banded or segmental buckle gives a good result. The last this is a patient with a multiple break, okay, and with a posterior aura. Yes, the literature clearly show that combined surgery, scleral buckling with a vitrectomy gives a better result. The last slide is a 13-year-old male which having a stick injury, and the patient was diagnosed as a annular chorioretinal detachment with a cyclodiastolic cleft. So patient having a hypotony with a hypotonic maculopathy with a less vision. So we have found out the literature which clearly shows that encircle buckling gives the improvement of the vision as well as the intraocular pressure. And the take home message. Thank you.